Good morning, and welcome to our third webinar in the Navigating Brain Health and Dementia series, brought to you by the American Medical Association in collaboration with the Centers for Disease Control and Prevention. I'm Dr. David Azis, Chair of the Board of Trustees at the American Medical Association, and it's a pleasure to be with you and to lead this important discussion. When caring for a person with dementia, you have to coordinate with a team of people. Each dementia care team is unique, but many include primary care physicians, neurologists, geriatricians, nurses, social workers, personal and professional caregivers, care navigators, legal and financial experts, pharmacists, psychologists, physical therapists, and more. Coordinating this many people and providing care for someone with dementia can be taxing physically, psychologically, socially, emotionally, and financially. And the burden often falls on primary care clinicians and family members. A recent report from the Alzheimer's Association found that over half of PCPs feel inadequately prepared to care for individuals with Alzheimer's or other dementias. And they also feel that there are not enough dementia care specialists in their communities. Additionally, nearly 13 million Americans provide unpaid care for a family member or friend with dementia. These findings reinforce the importance of developing strong dementia care teams to improve outcomes for patients, caregivers, and clinicians. Today, we'll be covering two issues: how a collaborative care model can improve the quality of dementia care, and how good communication between patients with dementia, their caregivers, and healthcare professionals in a care team can improve quality of life. We are joined today by two experts on dementia caregiving and care coordination, Dr. Gary Epstein-Lubau and Dr. Kalisha Bonds-Johnson, to share their perspectives and insights. Following their presentation, you will have the opportunity to ask questions of our panelists. Please join the chat to share any questions that you may have during the event. So let's begin with approaches to evaluating cognition. Our first presenter is Dr. Gary Epstein-Lubau. He is a geriatric psychiatrist and distinguished medical scholar with the Education Development Center. He is also professor of psychiatry and human behavior at the Alpert Medical School of Brown University and professor of health services, policy, and practice at the Brown University School of Public Health. Dr. Lubau contributes to leadership of the CDC Bold Center of Excellence for Dementia Caregiving and the National Dementia Care Collaborative, a project supported by the John A. Hartford Foundation to accelerate health system adoption of evidence-based comprehensive care for dementia. He has also contributed to projects related to the mental health of older adults, supported by the NIH, the U.S. Administration for Community Living, the Centers for Medicare and Medicaid Services, and the Patient-Centered Outcomes Research Institute, PCORI. Please welcome Dr. Epstein-Lubau.
Thank you, Dr. Azis, for the kind introduction. As described, I'm a geriatric psychiatrist working with Education Development Center and Brown University. And as you mentioned, I contribute to the leadership of the National Dementia Care Collaborative, which is a co-led initiative, co-led by Dr. David Rubin and my colleague at Education Development Center, Dr. Kristen Lees-Haggerty. And many of the slides I present today were developed by them or with them. The work of the National Dementia Care Collaborative is supported by the John A. Hartford Foundation. Next slide. I have no conflicts of interest to disclose. You see my other funding support listed here. And before I start with the content, I want to take a moment to thank the AMA for the opportunity to contribute to this important effort of education for primary care about dementia, and thank the AMA staff for assistance with developing this presentation, and especially thank Dr. Bonds-Johnson for the collaboration, as I've been learning from you as we prepared this. Next slide. I think back when there was a learning objective slide. Okay. that's fine. Great. Go to the outline slide. Thank you. The learning objectives for both my and Dr. Bonds-Johnson's talk are to identify common members of brain healthcare teams, their roles and responsibilities, and describe approaches to forming a brain healthcare team in different healthcare settings. I will follow this outline for my portion of the talk. I'll present background related to definitions of comprehensive dementia care, then describe the National Dementia Care Collaborative and related resources. I will include a brief overview of the CMS Guiding and Improved Dementia Experience Model, or the GUIDE model, and then all of this builds to descriptions of common members of a brain healthcare team. Next slide. Starting with the background regarding comprehensive dementia care. As shown here, there is reason for concern regarding dementia as people age. From 2025 statistics, 7.2 million Americans have Alzheimer's disease, and there is higher prevalence in African Americans and with people with less than a high school education. Mild cognitive impairment has a reported prevalence of 20 to 27% across age categories. And from 2026 reporting, 14% of people aged 57 to 85 show clinical symptoms consistent with Alzheimer's disease, and the number rises to over 1/3 of people above the age of 85. Next slide. Unfortunately, there has been historically poor quality of dementia care in the United States. A report from Jennings documented less than 44% of ACOVE quality measures were met. A cognitive evaluation was completed only 25% of the time following a positive screen for possible cognitive disorder. Medication evaluation related to memory was conducted only 9% of the time. Caregiver support was documented in less than 1/3 of cases. Monitoring of behavioral symptoms related to dementia was completed less than half the time, and there were poor linkages to community services. Next slide. In addition to the problem of poor care quality, there are high costs related to dementia care. Total costs in 2025 was $384 billion related to the person living with dementia. The bulk of this is attributable to hospital and residential care costs, plus there are costs related to unpaid care provided by the 11 million family caregivers, and this care sums up to an estimated $400 billion worth of caregiving hours. In the slide's right panel, you can see the differential costs higher to Medicare and Medicaid for people with dementia compared to those without dementia. All of this has contributed to the strong national push to improve dementia care. Next slide. This push to improve care is happening in the context of 74 million boomers reaching age 90 by 2036. There are new diagnostic markers for identifying people earlier in the illness course, and there are better descriptions of how dementia care is different from the care of other chronic illnesses, specifically regarding the need to engage family members and community partners in comprehensive approaches. Next slide. To define comprehensive dementia care, an accepted definition is that it includes the 8 elements you see shown here. Each of these components is necessary to meet basic care needs, including continuous monitoring and assessment, care plans, caregiver support, treatments for related conditions, and coordination of care. This approach is consistent with how the CMS Guide model is designed to deliver care. Next slide. There are many study findings showing that comprehensive dementia care benefits both providers, patients, and family caregivers. Results show improved quality of life, reduced neuropsychiatric symptoms, reduced caregiver burden and depression, improved caregiver self-efficacy, reductions in costs, including fewer emergency department visits and fewer hospitalizations, shorter hospital length of stay, and delay to the admission to long-term care, nursing home care. These results informed the development of the CMS Guide model, and the research successes also informed the development of the National Dementia Care Collaborative. Next slide. And next slide, thank you. There are 6 evidence-based comprehensive dementia care programs that came together to form the National Dementia Care Collaborative. They include Benjamin Rose Institute's BRI Care Consultation Model, the Care Ecosystem at UCSF, the Healthy Aging Brain Care Program at Indiana University, the Integrated Memory Care Program at Emory, Mind at Home at Johns Hopkins, and the UCLA Alzheimer's and Dementia Care Program. We know that each of these 6 programs can deliver all the elements of comprehensive care. The National Dementia Care Collaborative has been convening the leadership of these models to share best practices for how comprehensive dementia care can be elevated and reach more people. Next slide. The National Dementia Care Collaborative, or NDCC, was conceived by Dr. David Rubin preceding the CMS guide model and then actualized quickly when the guide model was announced. Specifically, the NDCC aims to improve access to evidence-based comprehensive dementia care and provide a learning community for health systems and community-based organizations interested in implementing a proven model of comprehensive dementia care. The NDCC approach includes understanding barriers and facilitators and health system pain points where implementing evidence-based programs, whether implementing them within or outside the CMS guide model. We do this by providing support through education and facilitating connections between health systems and the model teams. The NDCC website has information about each team and links to their websites and resources. Next slide. In the current phase of the NDCC's work, there are 3 goals. We are there to support participants in the guide model, sustain and expand infrastructure for improving comprehensive dementia care, and engaging strategic partners to extend the reach of comprehensive dementia care services. Next slide. Here you see the resources provided by the National Dementia Care Collaborative. We host an annual Autumn Summit, which is a multi-hour educational webinar to promote advancements in comprehensive dementia care. We also host monthly webinars addressing topics related to implementation of comprehensive dementia care. We held one yesterday on approaches to working with people who have a diagnosis of frontotemporal dementia or have a lifelong history of an intellectual or developmental disability and then develop a cognitive disorder in adult life. UCLA hosts a guide affinity group, which is for participants in the guide model to discuss solutions for technical aspects of implementing guide. And there are model-specific affinity groups which address the details of an evidence-based model. Coming soon will be an affinity group for members of America's Physicians Group to promote the uptake of comprehensive dementia care in Medicare Advantage plans. All of this, again, is available on the NDCC website. Next slide, please. I'll now give a brief overview of the CMS guide model, and you can go to the next slide. This shows several key moments in U.S. history related to improvements in dementia care. In 1980, the Alzheimer's Association was founded. 32 years later, 2012, the CMS Center for Medicare and Medicaid Innovation funded 4 demonstration projects through a Healthcare Innovation Award mechanism. Those results, and many others, were undergoing careful consideration in 2023 when an executive order was written to address access to high-quality care and to support caregivers. And in that context, also in 2023, the CMS guide model was announced. CMS requested applications for participation, and the participating health systems, which had an established history of providing comprehensive dementia care, began enrolling beneficiaries in July 2024, while new track participants, which were accepted into guide, were given time to complete further infrastructure development and began enrolling beneficiaries in July 2025. Next slide. The next few slides are directly from CMS's guide website. The guide model aims to improve quality of life for people living with dementia, reduce burden and strain on unpaid caregivers, and prevent or delay nursing home placement. The guide model will be evaluated on these outcomes over 8 years with the hope that positive findings will result in guide model care becoming a universal benefit and therefore fully available to all Medicare beneficiaries. Next slide. The guide model care delivery requirements are almost one for one with the 8 elements of comprehensive dementia care I presented earlier. One key difference is that the CMS guide model requires that every participating health system or community organization provide 24/7 access to their care team through a helpline, which can support beneficiaries and caregivers at any time. Next slide. At the launch of Guide, CMS produced this infographic, which is designed to show on the left fragmented care, which has been historically common in the US and is still prevalent, as compared with guide model care on the right, in which a person diagnosed and living with dementia and their family members are guided in a supportive fashion by a care navigator throughout a dementia journey. For those of you familiar with oncology care navigation or type 1 diabetes onset care navigation, you can think of dementia care navigation as similar. Next slide. Health systems and community-based organizations which have been approved as a participating site in Guide are required to have these members of their team. Here's a first look at the core elements of your brain healthcare team. Care navigators. These individuals can be clinically licensed or non-licensed, with the core components they deliver being assessments, engagement with patient and family caregivers, instruction and education, and implementation of elements of a comprehensive care plan. A lead clinician with dementia proficiency is required for Guide. This is defined as having, quote, experience for caring for adults with cognitive impairment, experience caring for patients 65 years or older, or specialty designation in neurology, psychiatry, geriatrics, geriatric psychiatry, behavioral neurology, or geriatric neurology, close quote. The Guide participant teams may also include other members, such as pharmacists and mental health specialists. Next slide. And next slide. I'll now go further into the common members of the brain healthcare team. Much of what I'm presenting now is included in an open access publication from last year in the Journal of the American Geriatric Society. That paper is titled Guide and Beyond: Strategies for Comprehensive Dementia Care Integration. And the paper describes actions that a healthcare system can take to improve its approach to delivery of dementia care. It outlines a 4-step process in which the dementia care leaders and needed partners build communication among each other. Then a value proposition model is developed and agreed upon by the system, including a financial plan and return on investment, financial and care quality goals for the organization. Then the program goes through a startup period, followed by cultivating the new program's maintenance and sustainability over time. Next slide. When building a brain healthcare team around primary care, one can consider these team members. Another arrangement is to have the brain healthcare team based out of a subspecialty, such as geriatric medicine, neurology, or psychiatry, with close intercollaboration with primary care. In Guide and other best practices, the primary care clinician retains all primary care responsibilities for the patient living with dementia. A dementia specialist is an essential member from neurology, psychiatry, or geriatrics. The dementia care navigator is, as described earlier, the central coordinator of everything related to dementia assessments, education, support, and referrals. And there are programs which add a dementia care assistant to help the dementia care navigator with responding to questions from patients and families and implementing referrals to services. A clinical social worker or behavioral health specialist can be a great addition regarding counseling for people living with dementia and for caregivers. And a psychiatrist or geriatric trained nurse practitioner can treat neuropsychiatric symptoms associated with dementia, including depression, anxiety, apathy, or psychosis. A pharmacist is a welcome member, especially to address the use of high-risk medications and to help reduce the total overall number of medications prescribed. Neuropsychology can be helpful in establishing a diagnosis of dementia type, especially in cases where the patient presents with symptoms that are not typical of Alzheimer's disease or vascular dementia. And finally, community-based organizations are essential partners to any effective brain health team. These organizations provide support services such as respite care and caregiver education, and Dr. Bonds-Johnson will be going into details of effective communication with patients and families. Next slide. On this slide, you see listed the technical partners which are necessary to implement and maintain the functioning of a brain health team. Your health system's population health program can help describe the return on investment, which will be achieved through better outpatient management of patients with dementia. The executive suite leaders will need to understand the win-win for the health system of improving dementia care. Electronic health record development and systems communication between IT and the billing cycle team is essential. And you'll see listed here again the community-based partners which provide respite care, caregiver education support, and other aging-related services which can be accessed through the local area agency on aging. Next slide. Regarding the creation of a compelling value proposition, including the financial modeling needed to demonstrate projected return on investment from a new brain health team, the Alzheimer's Association recently published a white paper and accompanying financial modeling tool, which is available for use. I just wanted to point you to that resource. Next slide. In my closing, this is my last slide. Another tool that is available through the National Dementia Care Collaborative's website is called the Dementia Care Improvement Instrument. This instrument was designed to help clinicians who are planning on building a stronger brain healthcare team. As your health system or organization completes this tool, as shown in the left-hand box, whether you are an organization participating in GUIDE or not, you're taken through a series of questions about your current dementia care resources, your current team members, and your preliminary ideas for how your system will improve comprehensive dementia care. Then, as shown in the center circle, the tool asks if you plan to implement one of the 6 evidence-based comprehensive dementia care models. And depending on your answers and on your potential interest in a consultation meeting, the tool provides feedback on your health system's alignment with one of the evidence-based models' affinity groups. Overall, the tool is a structured approach to thinking through your health system's current resources and the choices you might make for improvement. The tool can be found on the NDCC website, along with other resources. And one additional resource on our website that I'll especially highlight, it's on the resources tab, is Best Programs for Caregiving, which is a free online directory of evidence-based programs to support people living with dementia and their family caregivers. And I think the next slide is my handover to Dr. Bonds-Johnson. Yes, thank you very much.
All right. Well, thank you, Dr. Epstein-Lubau. We're going to shift our focus now to talk about how good communications between patients with dementia, caregivers, and healthcare professionals in a care team can improve quality of life. Our second guest, Dr. Kalisha Bonds-Johnson, is a nurse scientist, clinician, and advocate for African American persons living with dementia and their families. Her leadership, research, clinical expertise, and teaching are paving the way for national change. Dr. Bonds-Johnson currently serves as assistant professor at Emory University's Nell Hodgson Woodruff School of Nursing, a psychiatric mental health nurse practitioner at Emory University's Integrated Memory Care, and as the principal investigator of the DECIDE Research Lab, which focuses on creating culturally responsive programs to improve the quality of life for people with dementia and their family care partners, as well as improving the communication between families and primary care providers. Please welcome Dr. Kalisha Bonds-Johnson.
Thank you both. So again, thank you all for this opportunity to join today's conversation. My portion of the webinar focuses on two connected ideas. First, improving communication between persons living with dementia, families, and healthcare professionals. And second, improving quality of life for both persons living with dementia and family care partners. One of the biggest lessons from dementia care research is that communication is not separate from care. Communication is care. Good communication is good care. The way information is shared, decisions are discussed, and support is coordinated directly shapes quality of life, trust, stress, and outcomes for the families. I'd say even for the healthcare professionals. Next slide, please. Dementia changes more than memory. It can affect language, insight, processing speed, and the ability to communicate needs clearly. I know many of us already know that. Because of that, family care partners often become interpreters, historians, coordinators, and advocates within the healthcare system. Right now, about 7 million Americans aged 65 and older are living with Alzheimer's disease, and nearly 12 million family members and friends are providing unpaid dementia care. That means communication challenges are not isolated issues. They are everyday public health realities. Strong dementia care depends on creating shared understanding across the care team, not simply delivering information. Um, Earlier, we talked a lot about the different systems, and being at the integrated memory care, I can tell you that we are intentional about how communication is delivered. Families get info. For example, we have our own call. We have 24/7 calls specifically at the integrated memory care that is taken on by the members of the healthcare team. We ensure or strive to ensure that when someone comes to the integrated memory care, it is as integrative as it can be. We used to call it a one-stop shop, and I'm not sure that's totally true. I don't think there are any really one-stop shops when it comes to dementia because families need so many things outside of what the healthcare system can give. But we do provide we have the providers, we have the behavioral health, social workers, we have nurses, and we have amazing administrative personnel. And so I'll go into some of the specifics as we go along. Next slide, please. Communication breakdown can happen at multiple levels. Again, as we're thinking about it, you have the patient, the family care partners, the healthcare professionals, the systems in which the healthcare professionals work. It's a lot of people, a lot of systems, a lot of levels. For the person living with dementia, there may be difficulty finding words, following complex explanations, and remembering instructions after visits. For family care partners, they may feel overwhelmed, uncertain about how much information to share, or caught between competing family perspectives. Healthcare professionals are often navigating limited time, fragmented systems, and inconsistent communication across settings. One practical reminder is to avoid speaking around the person living with dementia whenever possible, regardless of stage. Even when a care partner provides much of the history, the patient should still be invited into the conversation as much as they can. As I'm working through this slide and talking with you today, I'm thinking about how things run at the clinic in which I work and how I like to communicate with families. Um, there are lots of different strategies that I put into place, and I think that's because I've discovered that all families are unique. So I have some families that will send me messages before the appointment. I will say that's probably my least favorite because I'm often like in the zone when I'm in clinic because I'm not in clinic every day. And so the messages like an hour before the meeting, 2 hours before the meeting, sometimes or visit, sometimes actually don't get seen until I'm in the visit, which is not always the best use of my time. But I do like the idea of having the patient portal and having families communicate with me when they need to privately. I've also had situations where I have the patient speak first and then the family member speak, and then I get them together or vice versa. I have more time as a psychiatric mental health nurse practitioner. So my new appointments are an hour and my follow-ups are about 30 minutes. But I have flexibility because I'm not in the clinic every day. So if I run over on an appointment, it's not the end of the world because I don't have a huge caseload like many of the primary care providers. And so I do recognize there's some caveats in what I do. With the healthcare professionals in the moments when I am running behind, though, I have amazing administrative personnel that'll, typically I try to run 10 to 15 minutes behind at most. But if it's more than that, I have them call and say, hey, give this person a heads up that I'm running this far behind. We also, in the moment, same day, can switch appointments from in-person to virtual because it's set up that way. We recognize that sometimes the person living with dementia just isn't feeling it. And so if they're not feeling it, fine, we'll do a virtual visit. We become very nimble as a practice to be able to do that. Next slide, please. So small communication adjustments can significantly improve understanding and reduce distress. And I started kind of hinting at this in the slide before, but strategies that help include addressing the patient by name. And this has been interesting, especially across different cultures and ethnicities. Some people still want to be called Mr. and Mrs., whatever their last name is. Some people want to be called by their first name. And so it is as simple as finding out what that person living with dementia wants to be called and then addressing that patient by that name. I will say sometimes that will change over the disease process as the person living with dementia sometimes may forget that they're Mr. and Mrs. So-and-so, and that first name is oftentimes in there a little bit better. So sometimes over the disease progression, I've seen people change how they want us to refer to the person living with dementia just because we're wanting to still keep that recognition as much as possible, at least name recognition. Using plain concrete language. I don't talk to my patients in clinic the same way I speak when I'm at AGS or the Gerontological Society or GSA, when I'm at a conference, when I'm Dr. Kalisha Bonds-Johnson, and in this research space, I speak very differently. I use a lot more jargon than I do when I'm in clinic. I actually have my patients call me Kalisha in clinic. I don't typically have them call me Dr. Bonds-Johnson. A lot of them will, just out of respect for the degrees that I've earned, but really it's not about those accolades in the clinical space. For me, it really is about meeting people where they are, and again, creating rapport and speaking simply. Slowing the pace of the conversation, y'all, as you hear me talking, that is not something I'm good at. So I've had to get really good at bringing water in, taking a sip of water just to slow my cadence down, because I know when I speak, I do tend to speak a little faster. Giving my families and the patients permission to say, hey, could you repeat that again? I didn't quite hear it. The other thing is when I was younger, I would go into my higher register, and we know if individuals are harder hearing, it's better to go into your lower register. So just being mindful of not only pace, but how we're saying things to help with ensuring that there is positive flow of communication, presenting one idea at a time. And so I often tell the clients that I focus on appetite, sleep, mood, and memory. Appetite and sleep, I lead with what's easiest, usually not a lot of pressure there. And then we talk a little bit about their mood, which sometimes, depending on the patient and the family, can be a touchy subject. We don't often talk about emotions a lot, especially in like a primary care visit. And then, of course, addressing cognition and memory. Repeating and summarizing key information. So I often like to give, okay, so this is on my to-do list. You've asked me to check on this item and this item and this item with the healthcare team or other care team members. I'm also going to follow up in the patient portal or give you a phone call if I need to. The other thing is, and I want to make this completely clear, is that I don't do all things in the practice. So, for example, if we discuss a medication change in the visit, I'm also going to send a message to nursing to say, hey, depending on what medication I'm prescribing, I've explained to the family that we should see one of three things: no change, it should get better, or it should get worse in X amount of weeks, X amount of days. Could you follow up on this day either in the patient portal or by phone, depending on what the family prefers, because we use both in the clinic, um, as a way to sort of figure out, are the medications working? Because oftentimes I don't, I typically have the leisure to see my clients monthly if I needed to, or every 2 months. I know other practices don't necessarily have that flexibility. So if you're seeing someone every 3 to 6 months, especially if they're having any behavioral and psychological symptoms, they can't wait that long. We need someone to check in a week, in 2 weeks. If I'm adjusting sleep, it doesn't take months to figure out if the medications I'm giving to help with sleep are going to take that long. And so how can you utilize the other care team members that you have in your system to help you be more efficient? And then, I talked about repeating and summarizing key information, and then confirming, understanding, and using teach back techniques. And sometimes, that's as simple as putting some additional information in the note to remind me what I said I would do, but also for the other members of the healthcare team to see what I'm doing, what I was thinking when I prescribed this medication or we discussed this non-pharmacological strategy. It's also important to ask families how they prefer information to be shared and who should be included in decision-making discussions. So I also will have family members in the visit. I've also had them on the phone. If the patient is in a long-term care facility, I have talked to wellness directors and directors of nursing in the visit. So I do try to bring all of the people whenever necessary. And again, I have that flexibility. I do have a little bit of a longer appointment, and I'm not having to do an entire review of the whole body systems. We're focusing on some key elements as the behavioral health specialist. But understanding what your clinic, healthcare system has the capacity to do, what you're comfortable doing, and then how they prefer information, I've just found it just improves communication. These approaches support person-centered care and help preserve dignity while reducing avoidable confusion. I do have a few clients that also don't want to use the word dementia. And so a lot of times they'll send a reminder. Either they'll tell the triage nurse or someone at the front desk, remind the provider, we don't use that word in here. And I'm comfortable not using the D word. We don't have to say dementia. It's charted in the appropriate chart. The family knows. But if that is a word that is upsetting to the patient, we can talk about confusion. We can talk about memory. And then using whatever word they use to describe their memory, confusion, cognition, I found, again, just kind of helps tremendously in improving communication. Next slide, please. So when we discuss quality of life in dementia care, families often think only about safety or symptom management. But quality of life is so much more broad. Quality of life is much broader. It includes comfort, function, relationships, identity, joy, meaning, autonomy, and emotional well-being for both the person living with dementia and the care partner. Research consistently shows that care quality improves when clinicians ask not only what stage is the person in, but also what matters most right now. And sometimes what matters most to the person living with dementia is going to differ from what matters most to the family, the care partner, the caregiver, whatever word we're using, because again, each family's like certain words when they're describing their role in this process. And those answers may change over time. Our care plans should evolve with them. So again, when we're thinking about comfort, are we assessing pain and sleep and mood? Function, are they able to do their activities of daily living? Are we supporting meaningful activities for as long as we can? Connection with the relationship. And I do want to say that not everyone, I know we use it a lot in healthcare, but not everyone is caring for a loved one. And so being cognizant of some relationships have been damaged, some have abuse and neglect, and we still have to be able to support both the person living with dementia and that care partner through that difficult relationship. But creating the space for people to be able to share that that's what's happening is important, because oftentimes I have found when a care partner is caring for someone who has been neglectful or unkind to them, they don't share it, and you have to get You have to build enough rapport to figure that out. But there are different strategies that they will need in order to make sure that they're safe in that relationship. Of course, managing dignity and choice, and again, the care partner well-being. Next slide, and I do believe it's almost my last one. So family care partners are essential members of the dementia care team. We cannot do this work without care partners. We cannot do it without family members, but they are also individuals with their own physical and emotional health needs. About 49% of dementia caregivers report high to very high emotional stress. Many also report unmet needs related to care coordination, navigation, and communication across health systems. And 2 in 3 Americans want brain health guidance from a healthcare provider. Simple clinical questions can open the door to better support. What feels hardest right now? Where are communication breakdowns happening? What would make this week more manageable? Providing clear next steps, written care plans, caregiver education, and referrals to community resources can improve stability for the entire care unit. And I'm not expecting you as the healthcare clinician to know all of the community resources. That's not necessarily your expertise, definitely not my expertise, but we do have a wonderful social worker. I do have colleagues and other friends who are in the research space that give community resources. So again, having that network that can support you as you support these families is just invaluable. And then next and last slide. So I'll close with a few key takeaways. First, communication should be treated as a routine clinical intervention in dementia care. Second, include both the person living with dementia and their care partner and any other family members whenever possible. Third, consistency matters. Families benefit when messaging is aligned across providers and settings. And finally, supporting the care partner is not separate from patient care. It is one of the strongest ways to stabilize care, reduce distress, and improve quality of life over time. So thank you.
Well, thank you, Dr. Bonds-Johnson. Those were some wonderful insights. So now we'll move to our question and answer portion where I'm looking forward to hearing what you both have to say. We're going to start with some questions that our audience members submitted during registration. And I encourage participants to join the chat to submit any additional questions that you have for our experts. We'll try to get to as many of the questions as we possibly can. So first, for you, Dr. Bonds-Johnson, if you had to pick 2 top strategies that can help make sure that the team is treating the patient and not the diagnosis, what would they be?
Oh, that's good. My first and favorite question always is to ask what the person living with dementia did, like before dementia, before retirement. Sometimes you get a clear idea, like were they a homemaker, were they a business owner? What did they do? Because I feel like that gets sort of at the essence of who they are as a person. Probably the other thing would be figuring out that relationship between the person living with dementia and who brought them. Was it a wholesome one? Was it a loving one? Was it strained? Was it challenging? I think that also speaks volumes in trying to understand how you all are going to work together as a team.
Okay, thank you. So, Dr. Epstein-Lubau, it can be very hard to know what resources are out there to support patients and care partners. How can physicians and other care team members find out what's available in their local area? Are there databases or other places that they can look into?
Great question. Yes, there are a number of resources. If there's a local Alzheimer's Association, you can ask them, and they may know right away best ways to engage your patients. There is often a convenient area agency on aging, which has all types of services for older adults, and they'll have those services organized by those that are available for people living with dementia and for family caregivers. And there are some online databases. So the Alzheimer's Association maintains a community resource finder that's national. And I mentioned on my closing slide, best programs for caregiving, which is a wonderful resource. This is a resource developed by Family Caregiving Alliance and Benjamin Rose Institute, and it includes the 6 evidence-based programs I described during my talk, plus 25 or 30 other evidence-based programs that are not comprehensive dementia care, but are for patients living with dementia or family caregivers, and all have an evidence base behind them. And they have a locator that's a free online tool to look for the types of services that you want and whether they're available in your area. And there was one other, I think that's it. Yeah, great question. And there are lots of, no, I did want to also mention that related to Guide, the CMS Guide website has a locator for Guide services. So if you don't know right away if there's a Guide provider in your area, CMS has a way to check, and there are also some national Guide providers that are non-local that may be available to patients in your location if there's not a regional Guide provider.
Okay, thank you. One of the questions that just came in on the chat, Dr. Epstein-Lubau, is that you mentioned the high cost of dementia care. Are there resources available for individuals who cannot cover the cost?
It's a case by case basis. So for a patient who's eligible for Medicaid, then there are a good number of home and community-based services that, as I mentioned, the Area Agency on Aging or the local Medicaid organization should be able to link people to services. And there are some sort of unique programs, like I just learned that the Association for Frontotemporal Degeneration has a program of providing respite for people who are diagnosed with FTD. So once there is a diagnosis, then there may be other resources that are available for low cost or no cost related to that diagnostic entity. And this would be a great question also, Kalisha, for you. I don't want to, I'm really curious what you would also have to say about resources for people, resources being expensive and how we get them to people who can't afford them.
I, I think you highlighted what we know. I would say one thing I have shared with people also is participating in research. So sometimes you can get different needs met because you're a research participant. It may not be long term, but sometimes the access you can get by being a research participant is another way to at least get some needs met and then potentially connect you with resources you were unaware of.
Okay, thank you. Another question that just came in on the chat revolves around the guide descriptions that originally recommended the inclusion of occupational therapy practitioners, but in the current, apparently now they are omitted in the current list of brain health team members. Do you all have any comments on that?
I can start. If you can get an occupational therapist on your brain health team, yes, yes, yes. They're hard to find, but they are able to match patient functioning and current capacities to needs in the current environment. They're the best experts I've found at being able to assess what are the current functional abilities and then what interventions can be person-centered matched to address their vulnerabilities with what capacities they retain. So I've learned a lot from occupational therapy and rely on them whenever I can.
I completely agree. Yeah, I completely agree. I don't think they were omitted because they're not necessary. I think they were omitted because they are hard to find. But if you find one, they are worth their weight in gold.
All right. This question is for both of you. Are there ways for health systems and hospitals to build better infrastructure to better support their brain health teams?
I'll start on that one. And we speak to some of this in the publication in JAGS, in the early phase of planning to improve dementia services. So one resource may be from your population health team just to know where the people living with dementia are regarding cost risks. Um, and then building connections across services, so between neurology and primary care, to understand what are the sort of best local practices, best local culture for how to do shared patient care. Those are all part of the early phase. And if there's ideally there is someone we might term a practice change leader or a dementia champion who has ideally both the time, energy, motivation, and some position of empowerment within the health system to ask questions about making change. That practice change leader can be really instrumental in getting things organized and then moved forward in a stepwise fashion.
And I think the only thing I would add is that I would like to see more cross communication between those that are in the executive suites, the leadership of hospitals and clinics, and those that are actually boots on the ground doing the work. I think sometimes there's a disconnect between, I think everybody wants the healthcare system to win. We want patients to be healthy, but the approaches to which we go about that don't necessarily always align. And I think part of that has to do with not necessarily knowing what each other is talking about, prioritizing, or doing.
I think that's a very cogent observation. I think most physicians and nursing staff feel similarly about a broad range of diagnoses and care rendered in large systems. So one more question. What are the best ways that you have found to cultivate a shared understanding with patients and caregivers, particularly in difficult situations?
Oh, difficult situations are going to come up, right? We're all human. We're going to see it differently. The care partner, again, has a set of priorities, often very different from the patient. I always like to think of what matters most to the patient, but what matters most to the care partner, family member may align, may be slightly different. And so, how do we compromise in a way where both people still feel like they win? That sometimes takes multiple conversations. That is not necessarily the role of the physician, clinician, provider either. So I usually start that conversation and then I'm like, we need to refer you to the social worker because I think we need to work through this in more sessions, in more thoughtful discussion. So when you have 15, 20 minutes, that is not the time to try to necessarily solve all of the difficult conversations, but at least to plant the seed of what other healthcare provider could you refer them to help them get on the same page?
I agree. And I'll build a little bit on what you closed there with Dr. Bonds Johnson about another healthcare provider. And um, I sometimes do this. I'll ask if there are other support people that I'm not communicating with who could be a resource to this family situation. So if it's an older adult couple, are there any adult children that are aware of the struggles that you're having that could contribute to this conversation? So looking for additional resources that exist within the family when things get really complicated can sometimes gain some traction.
This question just came in. I know I said that was the last one, but I thought this was a good question. The NDCC looks like a really helpful resource. But what about individuals who are not located near any of the model developers?
That's been addressed. It's a great question. I think that I it, it Dr. Bonds Johnson, you can answer this question related to integrated memory care. The other models are not tied to their geographic location. They've established what might be called like a dissemination site that is distant from the university setting from which they were established. So if a health system or community-based organization is really interested in one of the particular evidence-based programs and wants to set it up in their home setting, that's what the consultation process and the affinity groups are for, is to think about bringing this to your your current operating procedures wherever you are.
Yeah. And I would say at Emory, while who we serve is sort of geographically bound, I think if someone is interested in taking this model and creating a version of it, I don't think anyone at the integrated memory care would turn down that opportunity. Um, I think we're all just trying to learn how do we take as many of those eight, you know, identified factors that were highlighted and create a system that works as best as it can, as close to the model, recognizing that all won't, but to strive for that. How much better would that care be because you're striving for what we know to be best practices?
Well, this has been a great discussion, and I want to thank both of you again. Incredibly informative about a very challenging topic, with a lot of suggestions for ways to how to build a brain healthcare team and improve the experience of those with dementia and their caregivers. I think every one of us who takes care of patients sees many, many, many families who've been impacted by this. As we close out today, if you're interested in claiming CME credit for the discussion, log into our free AMA EdHub account and click on the Take the Quiz button. This is the third webinar in a multi-part series, and if you missed our previous sessions, you can find a link to view the recordings in the chat. Thank you for participating today.